Invite Dr. Gana Ajoy, who is a consultant VR surgeon at Rani Menon Eye Care at Thrissur, for her talk on closing macular holes, tips and tricks.
Am I audible? Yeah. At the outset, I would like to thank KSOS and Dr. Divya for giving me this opportunity. So my topic today is closing macular holes, tips and tricks. So as you know, modern surgical interventions that we have, they treat macular holes to more than 90% nowadays. And current surgical treatment is pars plana vitrectomy with ILM peeling, ERM if present peeling, gas endotamponade, and prone position post-operatively. Most of the common holes, which is idiopathic macular hole, it's seen in 8.69 eyes in 100,000 cases, which is the incidence. And the secondary macular holes, which include in high myopia, trauma, PDR, and various other retinal pathologies. When we talk about closing macular holes, let's get to the pathogenesis, or how does this actually happen, and how can we close this? So in most cases of idiopathic full thickness macular hole, there is believed to be an antero-posterior traction, a tangential traction, or both occurring or being exerted at the posterior vitreous cortex at the fovea. So vitrectomy is useful for addressing this important mechanism, mainly for antero-posterior traction. And tangential traction is dealt with by removing the adherent, residual adherent cortical vitreous with or without an epiretinal membrane present in that eye. And gas endotamponade, this helps us to oppose the macular hole edges closer. Now, just to go through vitrectomy, this is a 25 gauge vitrectomy. 3 ports with infusion and 2 active ports have been placed. And we go ahead with a core anterior and core vitrectomy. So at this point, what we can do is we can use tricot staining of the vitreous. This helps us to lift the complete vitreous and avoid leaving any vitreous remnant in the eye. Then we can go ahead with staining the internal limiting membrane. I've used brilliant blue dye in this eye. ICG was used earlier. It was said to be a little toxic, so nowadays we are using brilliant blue most of the time. We can go ahead with ILM peeling even without staining. I'm using the pinch and peel technique here to lift the ILM, and going ahead, this is a little more difficult for me to pick in this case. And I've lifted, and I'm going ahead with a macular excess in this eye. Yeah. So the completeness, so at the extent of peel, we can say beyond the fovea, around 1 or 2 disc diameters beyond the fovea is adequate. Arcade to arcade in case of non-closure of holes or a reopened hole posteriorly. You can consider removing the rest of the tangential traction. Doing a fluid air exchange at this point to keep the macular hole and the edges as dry as possible. A thorough macular hole, a thorough fluid air exchange, and putting in gas, either C3F8 or SF6. In this case, I've used a C3F8. So another technique to lift up the ILM, especially as a beginner, if it is difficult, what I initially used to do was use a pick. In this case, I've used a 25 gauge instrument that I've bent at the end as a pick, and I'm using it to just open up the ILM, just get an edge in the ILM, and then continuing the rest of the surgery with the forceps. So the mechanism of closure is gliosis. This is induced when I'm peeling the ILM. There is an activation of the Muller cell fragments in the ILM, and this induces gliosis and closure. And Muller cells are said to we can produce photoreceptors. It is said to produce photoreceptors even following a toxic injury. Now, suppose there is an ERM present. Peeling of the ERM increases the rate of anatomic closures to around 67% in comparison to 35%. So this is associated with a statistically significant ILM peeling as such. If we have peeled it, the reopening of a macular hole is said to be less likely. And excessive ERM itself can contribute to the reopening of macular holes. There is no significant difference in SF6 and C3F8. But if there is a resurgery, perhaps C3F8 is the gas to use at that time. Face down posturing is said to give some superior visual acuity gain, but it is controversial. Does it actually give us any advantage in anatomical closure is not known. So closure, there is either type 1 or type 2 closure, closed without a neurosensory deficit, that is type 1 closure, and type 2 is closed with some degree of neurosensory deficit. Other closure patterns include U closure, V pattern of closure, and W closure. This is a gentleman, so timing of closure, it is said to be that at around 1 month, most of the holes closed. This gentleman at 1 month had still some area of hole to be closed, but the eventual closure only occurred at 5 months. This was his 5 months OCT. So what causes a hole to remain open? Anatomical failure usually in a longer duration hole or a hole diameter that is greater than 400 micrometers. If the hole form factor is greater than 0.9, it has a good prognosis, and less than 0.5 is a poor prognosis. Even a high myopic macular hole, say greater than 26 to 30 millimeter of axial length, keeps the hole open. And reopening of hole, what is said is that the Muller cells itself can undergo apoptosis, and this leads to apoptosis of the photoreceptor cells and leads to a reopening of the hole. So what can we do in such closed holes that we know may be difficult to close? Now the technique is inverse macular hole, in which we open up multiple areas of ILM around the hole, bring it up to the edge of the hole, and insert this into the hole. So if you're taking a bigger flaps, you can use a cutter to just trim the edges. And if there is a lot of flapping of the ILM, you can use the assistance of a PFCL to keep it steady and then place the flaps back into the hole. You can also do this procedure after a fluid air exchange and keep the flaps into the hole. In an inverse flap, how does this help us? It provides a scaffold, and this causes Muller cell proliferation, helping the hole to close. It also provides a barrier to prevent vitreous fluid from entering the hole, thus allowing the subretinal fluid reabsorption via the RPE. And the gas also provides an additional scaffold in this case. So ILM flap method initially used a multi-layered membrane. You can use a single layer membrane. It is a more physiological structure. A recent technique is a temporal ILM flap. So this is a temporal ILM flap. And what we do is we open up the ILM in a line fashion at the temporal edge, and like a hinge, we pull up the ILM and close it over the macular hole and leave it there. So again, if this is flapping too much, you can use PFCL assistance or use fluid air exchange and keep it over there. So in cases where we know that this is a too large a hole, what is another technique you can try is you can try a retinal massage. You can push it towards the eye, and you can see in this eye it is actually becoming closer. People have also used a retinal massager for the same. So other modalities includes an autologous free ILM flap, or you can even use anterior or posterior capsule of the existing lens. A human amniotic membrane graft has also been tried, and relaxing arcuate retinotomy, subretinal incision, and hydrodissection are some other modalities to try and close the hole. So visual gain. So if you have a hole less than 1 year, there is greater chance of visual gain. Cases where there is an earlier macular hole, again, greater visual gain. It is said that intraoperative ILM peeling itself causes a better visual gain, along with a full thickness macular hole with a subretinal fluid cuff. We are looking for a continuous ellipsoid-zoid junction with a continuous external limiting membrane and an increased photoreceptor outer segment thickness. This predicts a better functional outcome. With the other minimal visual gain, if you're closing a chronic macular hole, perhaps the visual gain won't be as good, but metamorphoxia will still come down, and type 2 or W type has a less favorable outcome. Thank you.
Thank you very much, ma'am, for that nice talk, and thank you for finishing the whole in time.